hypersensitivity. Are we going too fast? No, because we all discuss this in general medicine. So, but still we have a religious responsibility of reviewing it in pathology also before we go to exam. Now, hypersensitivity. Let's talk about it. I think today our online classmates are all very happy. No advertisement interruption in the middle, and it is going comfortably for everyone. Now, doctor, 4 types of hypersensitivity we all studied in medical school. But already 5th type 5 hypersensitivity also had been added to the classification. So let us talk 3-4 important points about each of it. Type 1, what do you call? Immediate or anaphylactic hypersensitivity. It is the immunoglobulin E, which is the most important mediator. Who produces immunoglobulin E? Any immunoglobulin is basically produced from B cell, plasma cell. Then when will B cell will produce it? There is an allergen or an antigen which stimulates the B cell to produce the immunoglobulin E, which is the central immunoglobulin. For the type 1 hypersensitivity reaction is what need to be remembered. So, the IgE antibody which is produced by the B cell, it becomes bound to the Fc receptors of the basophils and tissue mast cells. So, mast cells are feeling ready to explode any moment. Suppose if there is a subsequent exposure, first is sensitization, then the antigen reacts with that bound IgE antibody and that lead to the development of the mast cell degranulation, which lead to all the reactions which you see in the case of type 1 hypersensitivity. Common question asked is there any role for complement in type 1 hypersensitivity in this entire process? No, sir. Complement is not involved anywhere. So let us look at it. Allergen, Fc receptor of immunoglobulin E, allergen specific IgE, and the degranulation of the mast cell is all about type 1. So this is the B cell, and the allergen has sensitized the B cell, and immunoglobulin E, which is being bound to the Fc receptor of that sensitized mast cell, is waiting for the second exposure with the allergen. The moment second exposure occurs, it will undergo degranulation and release the various inflammatory mediators. We have seen the other day, eicosanoids, how much we call mast cell as a chemical bomb. So, some of those vasoactive amines will lead to smooth muscle contraction, small blood vessel to undergo capillary permeability will increase. Then it has effect on mucous glands, sensory nerve endings, eosinophils, etc., etc. So the most important key event which initiates a type 1 is the allergens cross linkage with the cell bound immunoglobulin E and the antibody cross linkage of the IgE, and ultimately the degranulation reaction is what need to be remembered. So, how will you test that a guy is having a type 1 hypersensitivity state and allergy? So, you take that suspected allergen and try to place, and already Fc bound immunoglobulin E containing mast cells are waiting for that exposure. The moment exposure occurs, they degranulate and that produces that local reaction. So, using that skin test where the various allergens are used to elicit the immunoglobulin bound mast cell degranulation reaction is a way to test for the presence of the allergy. So, the degranulation mainly release the histamine. Histamine increase the vascular permeability. Then another important feature of type 1 reaction is One of the mast cell degranulation product is a strong chemotactic factor for the eosinophils. Hence, eosinophil infiltration is one of the classical features of the type 1 hypersensitivity reaction. Note the clinical examples of the type 1 hypersensitivity reactions. Allergic reactions, atopic reactions, seasonal rhinitis, and allergic asthma, urticarias, and some people can get systemic anaphylaxis when you call anaphylactic shock, where they will rapidly have urticaria, bronchospasm, laryngeal spasm, shock, with very trivial exposure, you know. Some people will have dusting allergy. So MBBS third year exams are over. Very, very happy. Pathology is over, pharmacology is over, microbiology is over. Goodbye. So we are into the final year. First let us clean the room and then get ready. Then have one small bachelor party and then once more start preparation program. So you thought like that and started dusting the room and getting a huge allergic reaction and ending up in intensive care unit. So that's the reason today is promisable, yesterday is forgettable, tomorrow we are never sure. So enjoy the today itself. So doctor, the exposure to the offending antigen is a predisposing factor for that. Then angioedema is another expression where the lips, eyelids, etc., laryngeal edema, they all develop in the people who are having the type 1 hypersensitivity. Now one important fix that you need to know is, allergic angioedema is different from hereditary angioedema. Very important to be remembered. A lot of times this comes as a small MCQ to trickle you. Hereditary angioedema is because of C1 esterase deficiency. In these people, the serum C4, complement 4 is low, and the other complements like C3 are consumed. So it is a problem of complements, not that of hypersensitivity, not type 1 hypersensitivity. Don't get confused for type 1 hypersensitivity associated angioedema and hereditary angioedema. A lot of times examiner like to test you whether you know this point or not. Then type 2. Type 2 is called antibody mediated or a cytotoxic hypersensitivity. So in this, there will be complement fixing antibodies which will be reacting directly with the antigen, and that where is that antigen located to which these complement fixing antibodies are going and fixing up? It is in a fixed tissue. It is in a fixed tissue. For example, good pasture syndrome. Who is the antigen for the good pasture syndrome? Glomerular basement membrane and pulmonary basement membrane. Where is that located? Is it freely floating in plasma? No, it is fixed in the tissue. To that, this complement fixing antibody will go and bind and lead to the development of damage. So that is the whole story. Since complement is involved in this, patients with type 2 will show hypocomplementemia. Type 2 hypersensitivity reaction mediated clinical scenarios, hypocomplementemia will be there. And where is that antigen located? It is in a fixed tissue like a basement membrane or a RBC membrane, etc., etc. They need to be sure. It is fixed to the RBC membrane, not free floating in plasma. What is the difference between this and post-streptococcal glomerulonephritis? There the streptococcal antigen is free floating, okay, and antibody against it is also free floating. They both met, immune complex is formed that goes and attacks the kidney. There is an immune complex deposition state. That is different, okay. So antigen which is fixed in a tissue like a RBC membrane or a basement membrane is the one which is the target in case of type 2 hypersensitivity. So what are the clinical examples? We have warm antibody autoimmune hemolytic anemia, hemolytic transfusion reactions. Don't forget. Any RBC membrane may fixed antigen is being attacked means that becomes type 2. Then hemolytic disease of the newborn in case of the erythroblastosis fetalis is also an example of type 2 hypersensitivity. Then good posture syndrome is another example of type 2 hypersensitivity. Then we have what is called ADCC. That means antibody dependent cell mediated cytotoxicity is another example of a type 2 hypersensitivity reaction. What will happen in this? The antibody will react directly with the integral surface antigen of a targeted cell. And you have a free Fc portion of that antibody molecule, and that reacts with the Fc receptor on the cytotoxic leukocyte, and the cytotoxic leukocyte's attention is drawn towards the tissue. It will go and attack it. In antibody dependent cell mediated cytotoxicity, what will happen? Antibody will identify, doctor, this is the cancer cell or this is a virus infected cell. So what it will do? That antibody will go and bind with that, and it will keep its Fc portion up. It will be saying, I have held this fellow a thief. Please come, chor ko pakad gaya, chor pakad gaya. It will be shouting. Then the leukocyte who is going on patrolling, the police officer, it will listen to this cry of the antibody. It will turn its car and come and attack the thief who is the virus infected cell or a tumor cell. Right? So, who is that policeman who is driving the car? It is NK cell, natural killer cell. Why only that policeman is able to identify it? Because that antibody has exposed its free Fc portion and calling the policeman. NK cell know how to identify that Fc portion of that antibody which is already bound to the virus infected cell or a tumor cell. Okay, doctor? Then, other than NK cell, who else can mediate antibody dependent cell mediated cytotoxicity? Why it's called antibody dependent cell mediated cytotoxicity? Ultimately it is the cytotoxicity. Why? Either NK cells, monocytes, neutrophils, eosinophils, one or the other is coming and destroying that particular tissue. Right? But by themselves they don't know where is the tissue located. It is this antibody which has gone and bound to that is calling the cell mediated immunity cells to come. So how foolish are our human beings, our scientists. Initially they said dogmatically, there are two different divisions like Vaishnavites and Shaivites. They can't mix at all. They said there is one cell mediated cytotoxicity which is only cells. There is one antibody mediated cytotoxicity which is purely antibodies. Antibody mediated humoral immunity. Later on they discovered they both are complementary. There are scenarios where antibody can invite the cytotoxic cell to come and kill the tissue. Kill the cell. Okay. So that is ADCC. Lot of times a question is being asked. How is the question asked? Bottom line is that because all our preparation is not for knowledge, no. It is for how to answer like a parrot. What is your name? My name is Parrot. Is your name Parrot? Yes, I is Parrot. So you must be in a position to answer like a parrot. So, commonly examiner will ask you two things. NK cells, ADCC. Fc receptor, ADCC. These are the two buzzwords which you need to remember. Is there any complement involved in this? No, sir. There is no complement involved in ADCC, is what need to be remembered. But otherwise, in all the other type 2 hypersensitivity reactions, is the complement is involved? Yes, sir, it is involved. Then type 3 hypersensitivity, antigen free, antibody free, they both met, they formed a complex, and the immune complexes generally are removed by the mononuclear phagocyte system. We have got a mononuclear phagocytic system which will be doing patrolling 24 hours in our blood. Wherever it finds any immune complex, antigen antibody complexes, immediately it will catch it and takes to the spleen, the reticuloendothelial system, and try to ward it out of the body. But if there is any insoluble immune complexes, then they are deposited in the vessel wall and in the serosal surface or the extra vascular sites, and that is responsible for all these immune complex reactions. Is the complement involved, doctor, in this? Definitely. Complement is involved in this. So immune complexes bind with the complement, which is highly chemotactic for the neutrophils, and those neutrophils will come and release the lysosomal enzymes, and that will ultimately lead to the development of destruction, is what need to be remembered. So that is all the story of type 3. So complement is definitely involved. Serum complement is definitely decreased. Then what else will happen when those immune complexes, what else they will do? They will call a lot of inflammatory mediators to be attracted to the place where the immune complex got deposited. Hageman's factor will arrive. The other day in inflammation we studied, no, Hageman factor is capable of activating kinin system, complement system, clotting system, everything it can, fibrinolytic system, everything it can activate, right? So it leads to the activation of the thrombosis, it leads to vasodilation and edema, it leads to platelet aggregation. All these are caused by the Hageman factor, is what need to be remembered. So what are the examples of the type 3 hypersensitivity, is my question to all of you, doctor. Serum sickness is a classical example of an immune. Once upon a time, they used to give horse serum. For everything there is a horse serum available. Okay, if some guy is not getting MD seat, means give some horse serum. Okay, so that he will start preparing like a horse for the tomorrow's exam. So that led to development of serum sickness, where the antigen antibody complexes deposit in the heart, the joints, the kidneys, etc. SLE is an example of an immune complex mediated type 3 hypersensitivity. Arthus reaction. What is the other name given for Arthus? It's called localized immune complex reaction, it is called as. Whenever there is an exogenous antigen, how will exogenous antigen can come into our body? Either you have injected it, or there might have been some organ transplantation where the donor's organ is appearing like a exogenous antigen, and already inside the body there are preformed antibodies against that antigen, and that lead to development of a hyperacute graft rejection, and that is an example of a type 3 hypersensitivity reaction, is what need to be appreciated. Polyarthritis nodosa, which is a generalized immune complex reaction where all these insoluble immune complexes go and deposit in small and medium sized vessels. Then among glomerular diseases, the other day we have studied immune complex mediated glomerular, which are type 3 hypersensitivity. PSGN, membranous glomerulonephritis, lupus nephropathy, etc., etc. Ultimately, we have what is called as type 4 hypersensitivity, doctor, which is also called delayed hypersensitivity, is what need to be remembered. So, the delayed hypersensitivity, who is the main mediator, doctor? CD4 lymphocytes. tuberculin reaction. And HLA class 2 antigens on the macrophages are very important part of it. And that lead to development of memory T cells. So you are sensitized to tuberculin today means another few days later if I give you one more tuberculin test, you will much more strongly turn positive for that tuberculin reaction, second time, third time, fourth time, because it will elicit a CD4 positive memory T cells. So after the initial sensitization, on subsequent contact with the antigen, the CD4 positive memory T cells will hyperproliferate and lead to the release of the cytokines, and especially interleukin 2 and the other cytokines are very, very important. They stimulate the phagocytic activity of the macrophages, which will do all the required dirty job of the type 4 hypersensitivity is what need to be remembered. So similar to our type 1, in fact in type 2 also, in erythroblastosis pitalis also, initial exposure sensitizes, next exposure it will accelerate, right? Even here also we have a intracellular organism, bacteria like mycobacterium, which will initially cause the helper T cells to develop a memory, and subsequent exposure will make it to activate the macrophage, which will lead to the development of the typical type 4 delayed hypersensitivity reaction, in which you find granuloma formation as what you can see here. So examples are, we have a tuberculin reaction where after intracutaneous injection of tuberculin, there is a marked amount of neutrophil proliferation, perivascular cuffing and induration in a tuberculin reaction. What is it? Because of the fibrin which get deposited will lead to that induration. In fact, the calculation of that induration is a way to grade the tuberculin reaction, not the erythema, as what we have thoroughly discussed the other day. Then contact dermatitis. So it is also because of a delayed hypersensitivity reaction. Now in this context we need to know what is called as cytotoxic T lymphocyte mediated cytotoxicity. What is the meaning of it? Basically in this, the CD8 plus, not CD4. You have cytotoxic T lymphocytes, CD8 positive T lymphocytes are there, no? They are the ones which mediate the killing of the target cells. Where do we use cytotoxic T lymphocyte mediated cytotoxicity? Just like ADCC you have seen, antibody dependent cell mediated cytotoxicity. Similar to that, you have a cytotoxic T lymphocyte mediated cytotoxicity. Tumorous cells, virus infected cells, if our body want to eliminate it, what will it do? It is the cytotoxic T lymphocytes which will go and attack directly and kill it. And how will the cytotoxic T cell know that this is a virus infected cell? The moment virus infects a cell, that cell will express the infected cell will express the receptors for the CD8 T cell to recognize it. Then CD8 T cell will go and attack it. Then this come to know, some microbial organisms came to know about this because they are reading microbiology better than us. Then what some microbial organisms started doing? They are infecting the cells, viruses, and not letting that infected cell to express the helper T cell receptor, so that the cytotoxic T lymphocyte mediated cytotoxicity cannot happen. We have seen in the discussion on the HIV, no? So that is possibility is always there. So what is that receptor on that virus infected cell which is going to attract the CD8 positive cytotoxic T cell? The moment virus infects or the moment cell become cancerous, it starts expressing HLA class 1 antigens, which will enable those cells to get recognized by the cytotoxic T cells, which will lead to the destruction of it, is what you need to remember. And unlike the other type of delayed hypersensitivity, where you have the cytokines involved, no? There are no cytokines involved in the process of cytotoxic T lymphocytes, because you don't need any macrophage or a joker like mast cell to release few small bulletins of chemical bombs and kill. Cytotoxic T cell will go and drill holes inside that infected cell and destroy it. It doesn't need all these cytokines, blah blah, is not required. So that's the point. Now comes, last but not the least, last but not the least is type 5 hypersensitivity. I think for Fahima and Anuja, the class is, the broadcast is getting interrupted, they say. Please check them. Earlier, see, there are two possibilities where the broadcast can get interrupted, either because of your local system problem or our broadcast problem. So yesterday I had a long debate with the broadcast company who is doing this broadcast. They said, Doctor, whatever you are broadcasting from your class will first go to New York City, the server located there. From there it become broadcasted across world. So that is the reason if you are using a ad supported broadcasting, then it has all the way need to go to New York and come back. But in this dedicated channel broadcasting, it will be captured by the nearest Mumbai server, from our system to Mumbai server. From there it will broadcast wherever you want it. So that is the reason today if anybody has interruptions, it is due to their local system and local internet problem, not due to the server problem. Yeah, day before yesterday when we used a ad supported one, that is due to the server's issue. So I request you, yeah, Sanjay says there is no broadcast problem in Guwahati. I am very happy. So technology has become so easy, doctor, nowadays. On a mobile phone also you can, if you have a strong internet backbone, yeah, you can be able to attend a world-class session from anywhere. So anyway, please check, please help them out. Maybe their local internet issues may be there. Now doctor, type 5 hypersensitivity. What is the meaning of it? If there are antibodies against the, there will be anti-receptor antibodies. Anti-receptor antibodies. But don't confuse for myasthenia gravis. Myasthenia gravis is also anti-receptor antibody against the nicotinic receptor of the acetylcholine in the post-synaptic area. But that is not type 5. Type 5 means there is a development of an anti-receptor antibody against a particular cell surface receptor protein, but that anti-receptor antibody, instead of destroying that receptor, right, will stimulate that receptor. It wanted to be enemy, but after meeting it became friendly, and that led to development of stimulation. So what is Graves' disease? In the Graves' disease there are anti-TSH antibodies, but anti-TSH antibodies have got a TSH-like effect, stimulating the thyroxine overproduction by the thyroid gland. What will TSH will be doing? TSH stimulates the thyroid to produce more thyroxine. So these antibodies are directed against the TSH receptors on the thyroid. But after meeting the TSH receptors, after binding, these antibodies, after they bind, they stimulate the thyroid to produce the excess thyroxine, just like TSH used to do. That is, TSH's enemy behaves like TSH. Right, doctor? So that is the type of reaction which is called type 5 hypersensitivity, is what need to be remembered. So that's all the story, doctor, about what we call as hypersensitivity reactions.